in the last years, attempts of de-escalating or reducing axillary treatment and thus reducing axillary morbidity in breast cancer patients have resulted in a lot of clinical studies. One of the first of those clinical studies was the Sentinel trial, a trial that actually was done and published in 2013 by Thorsten Kühn, and it was done to show the feasibility of sentinel node biopsy after neoadjuvant therapy. And there was a large number of patients in that, many thousand patients in that trial, and we are now actually working on that data set and trying to identify populations that may have no benefit from axillary surgery after neoadjuvant therapy. And in some abstracts we have presented in the last years at ASCO's and San Antonio meetings, and actually one of the main manuscripts is now, one is published and one is actually under review with the British Journal of Surgery at the moment. We have demonstrated that there are patients that have a very, very low risk of residual axillary burden after neoadjuvant therapy. Yeah, of course, you have to discriminate those between the patients who had clinically suspect lymph nodes and clinically occult maybe lymph nodes before neoadjuvant therapy. But in the subgroups of triple negative patients and HER2 positive patients, we see that if these patients have a PCR in the breast, their risk of really having residual disease in the axilla is lower than the false negative rate of a standard axillary dissection level 1 and 2. And this is why in a new trial that is just at the moment being set up, the UBreast-1 trial, in a European cooperative trial from the new UBreast group, these patients are offered after they have a PCR in the breast to be randomized between axillary surgery or no axillary surgery. And we all believe that we're on our way, that for selected patients after neoadjuvant chemotherapy, axillary surgery will no longer be necessary because their risk of residual disease is so low, especially those high-risk patients. On the other hand, in the INSEMA trial that was done by Thoralf Reimer in Germany with over 5,000 patients, we also had a lot of patients in that study. We did it the other way around. In low-risk patients with primary surgery, patients were randomized 4-to-1, sentinel node biopsy versus no sentinel node biopsy. So even in that situation, in primary surgery without neoadjuvant therapy before, we will have results in 3-4 years that may indicate that for selected patients, it is not necessary to do axillary surgery at all. And we believe that this de-escalation of surgical therapy will benefit the patients.